Hello everyone, welcome back to another session in dentistry and more. Today we have a topic from epidemiology or public health dentistry, that is screening for disease. So screening is nothing but actively searching a disease in apparently healthy people or a population. So hope you remember the concept of causation and iceberg phenomenon, where the iceberg represents the cases, but the tip of the iceberg is a symptomatic cases. That is only what we see. So these tip of the iceberg are the disease people with symptoms who goes to doctors for the treatment. But the majority, that is a 90% of the disease people, these 90% are asymptomatic, but they still has disease. They are below the water level. They don't know they have the disease, so they don't go to doctors for the treatment. So screening works in that section of the disease population, that is the asymptomatic cases. So screening is nothing but actively searching cases in a asymptomatic population or apparently healthy people. So uses of screening, the first one is the prescriptive screening, that is for our own benefit. So the doctors or healthcare person do screening in order to find out a disease in a healthy people. Okay, so screening procedures which is prescriptive in nature for the case detection, whereas a prospective screening, here the benefit is for the others, not for the person, because we are protecting these people in order not to spread the disease. It is very common nowadays because the COVID-19 disease, where we quarantine people with disease because they don't spread to others. It is actually benefiting the other people because they don't get the disease from the person. That is prospective screening for immigrants from infectious disease. Now for the research purpose, that is to estimate the prevalence and incidence, which can help the research people, and also to educate or to create awareness for lifestyle diseases such as diabetes, or to detect the disease so early so that the intervention can be done so early, so the complications or the mortality will be very less. So what are the types of screening? They are mass screening, high-risk screening, then the multiphasic screening. Mass screening is nothing but it is done on a mass of people, irrespective of any high-risk group or a particular risk. Just like the tuberculosis, which is very prevalent in third world countries like India, where 60 to 70% are having disease, but majority are asymptomatic or carriers. So in order to find the disease from such a huge population with 70% of prevalence, we need to do mass screening. We just cannot exclude any group because the disease is so prevalent. So in such cases, mass screening is the only strategy. The second one, that is high risk or selective screening, where only a particular group can be involved, such as if for diabetes we can just use people with 40 plus or people's parents with diabetes history, and if for breast cancer the women group of 40 plus can be particularly used, because majority of the cases will be in that sector, so we can just reduce our cost, workforce or time. Whereas this multiphasic screening, it is done on different phases for any disease. The first, it starts with questionnaire, then clinical examination, and then there will be investigation, which can be blood investigation or the radiographic investigation, because it is having many layers of investigation to find out the disease, but it is not having much benefit. It is showing increased cost. So what are the criteria of screening test? The three criteria is acceptability, repeatability and validity. Acceptability is nothing but it should be very acceptable for the people. Repeatability is consistency, and validity is accuracy. Acceptability, it should not be painful, discomforting or embarrassing for the people. Repeatability is nothing but the reproducibility or the consistency. The test should give consistent results when repeated more than once. So there are three factors which involves in the repeatability. The first one is observer variation, then the subject variation and technical errors. Observer variation, we have two things, that is intra-observer and inter-observer. Intra means within the same person, the same observer. If I am doing the examination, I should be doing it 2 or 3 times so that I can minimize the error by taking average. Whereas inter-observation is little more complicated because there are 2 people involved. So the proper training or the intensive training or the standardization of procedures only can minimize the error, because both person has to record the result accurately or consistently. So we need to train the examiners very well, or we need to standardize the procedure. Whereas these errors are common in cases of X-ray, ECGs, blood pressure or histopathological specimen, but it cannot be eliminated completely, that is there. Now the biological variation, it can be due to the changes in parameters or variation in perceiving the symptoms, and technical errors could be the defective instruments, the faulty reagents. But this is the most important thing in the screening test, that is the validity. How valid, how accurate the test in finding out the disease. So what extent test accurately measures which it intends to measure. The test which is to identify the HIV patients, or the test to identify the corona patient. So how accurately it detects the person with disease. Let's take the RT-PCR. Its accuracy is around 95%. Means if a population with 100 people with COVID-19 disease, the RT-PCR would be able to detect 95 out of 100. Still, it is not able to detect 5 people with disease. So that is the accuracy or validity. What extent the test can measure what it intends to measure. So it distinguishes those who have disease from those who do not. We can say glycosuria is a screening test for diabetes, but GTT, glucose tolerance test, is a more valid, just like the antigen test is a screening test, whereas the RT-PCR is a confirmatory test or more accurate test. So validity has two components, that is a sensitivity and specificity. So this is a picture you need to visualize when thinking about sensitivity and specificity. Before that, the validity means nothing but accuracy. So how accurate the result of the test to its true value, how accurate it is giving the test is to its true value. If 100 people are having disease, how accurately it is reproducing the test result. Whereas the reliability is precision, how close are the results of a test on repetition, that is reliability. Now we have some mathematical tests for the evaluation of screening tests. One is sensitivity, specificity, then positive predictive value, negative predictive value, percentage of false positive and percentage of false negative. So before moving on, you need to keep in mind that positive means case, negative means healthy people. False positive means false case, that is healthy person. False negative means false healthy, that is actually a case. So sensitivity, it is the ability of a test to identify correctly all those with disease, that is true positive. 90% sensitivity means 90% of the disease people are screened and they give the positive result, and 10% will be false negative. That means if a population of 100 people and we are having a test and the test giving 90 positive result, that is 100 disease people, and this test is saying that out of 100, 90 are having disease. So what about the 10%? This test is saying actually they are false negative. They are saying there is no disease, but they are actually having disease, right? Because all 100 people are having disease, but this test is able to detect only 90 out of those 100. The remaining 10 is false negative. That is sensitivity, ability to correctly detect the disease cases. Whereas specificity, identifying correctly those who do not have the disease, that is true negative. Before it was true positive. True positive means case, true negative means healthy. So 90% specificity means 90% of this non-disease people will be true negative. 10% will be false positive. That is, if 100 people we take and nobody is having disease, okay, this test is saying that 90% is true negative. That means 90% is not having disease, but it is saying that 10% is having disease, but actually they do not have any disease. So this is a error of this test. It is able to give only 90% of the specificity. That is, the 10% of the population, this test is giving wrong information. So that is sensitivity and specificity. Any test is measured in this two value, sensitivity and specificity. If you take any test, they will be mentioning about its sensitivity and specificity. So the perfect test is 100% sensitive and 100% specific. That is very rare. So let's take these all things into a mathematical table, that is A, B, C and D. A is true positive, that is it is actually a disease, and in test also it is giving positive. Actually it is disease, but in test it is giving negative, that is false negative. Okay, actually there is no disease, but in test it is giving positive, that is false positive. Actually it is no disease, and test also giving negative, that is true negative. So this is A, B, C and D. So total positive cases are A plus B. It also includes false positive. Total negative cases are C plus D. It also includes false negative. Total cases are A plus C, and total healthy or not diseased are B plus D, or without people without disease. So sensitivity is disease persons with positive test divided by all persons in population with disease. So this is the denominator, all persons with disease, A plus C. That is total case. So it will be disease person with positive test, A by A plus C. Whereas specificity is a non-disease person with negative test, that is D, divided by all persons in population without disease, that is B plus D. So sensitivity is A by A plus C, specificity is D by B plus D. So never learn this A by B, C by D, A plus B, C plus D, because it is very confusing. So you need to be very thorough with this concept. What is true positive, what is false positive, what is false negative and false true negatives. Next we have positive predictive value and negative predictive value. Positive predictive value is a proportion of patients who test positive who actually have the disease. So this is a proportion of patients with positives who actually have the disease, that is A by A plus B. A plus B is the total positives and A is the actual diseases from the total positives. Whereas the negative test is the proportion of patients who test negative who are actually free of disease. So D is the actual people without disease by the test giving, that is C plus D is the total negative by the test. So this is just horizontal, A by A plus B, D by C plus D, whereas the sensitivity is A by A plus C or D by B plus D, that is specificity. Now let's take an example where the total population is 1000. Out of them 100 is having disease, 900 is not having disease. Okay, so we have done a test in that 80 has given positives. So 20 is negative. This is a test result. Okay, actually 100 is having disease. So true positive is 80. Then the false negative is 20. True negative 800. This is what the test has given, and 100 is false positive. But actually 900 is the total negative or healthy, 100 is the total cases. But the test is able to give only 80 out of 100 and 800 out of 900 cases and healthy respectively. So total positives is 180 and total negatives is 820 and total. So let's see one by one what is sensitivity. Sensitivity is nothing but A by A plus C, that is 80 by 80 plus 20, 100, that is 80%, and specificity is D by B plus D, that is 800 by 800 plus 100, that is 800 by 900, 89%. So this particular test is able to detect 80 cases out of 100 cases, and this test is able to detect 89 healthy people out of 100 healthy people. So its sensitivity is 80% and specificity is 89%. So now let's see the positive predictive value. It is a proportion of people with positive among the total positive, that is 80 by A plus B. 80 by 80 plus 100, that is 80 by 180, 44%. This is a proportion of the positively tested among the total positive, or the cases among the total positives. This is a healthy people among the total negatives. It is 800 by 800 plus 20, that is 98% is a negative predictive value, and 44% is a positive predictive value. Now we have the percentage of false negative and percentage of false positive, that is C by A plus C and B by B plus D. It gives a percentage of false negative and false positive, because false positive is B and false negative is C. So just take the denominator of deceased and non-deceased. So this is an example, you can try it out. I have the answer with me. So you need to find out the sensitivity, specificity, positive predictive value, negative predictive value, and this percentage of false negative and false positive. So sensitivity will be 40 by 140, specificity will be 9840 by 9860. Then the positive predictive value will be 40 by 60. Then negative predictive value will be 9840 by 9940. So here you have the answer. Sensitivity 40 by 140, specificity 9840 by 9860. False negative is 100 by 140, false positive by 20 by 9860. Positive predictive value is 40 by 60, then this 9840 by 9940. So this is a mathematical evaluation of any test. Ideally speaking, sensitivity and specificity should be 100 or close to 100. Okay, so less than 90% won't be much accepted. So that is all about screening. The only thing is you need to be very thorough with these false positive and false negative. True positive and true negative are nothing but the cases and healthy people, and how we calculate the sensitivity, specificity, and never learn this A, B, C, D. Always try to understand the concept and then apply it, so you won't remember, you won't forget it for a very long period. So hope you understood this topic of screening. I'll come up with a new topic in dentistry and more. Thank you.